the teaching case.
Greetings from Singapore. Let me share with you an interesting case. This is a 20-year-old man.
Can you stop it here?
Who presents for EP study and ablation.
So this is the tracing that has been sent to us. There is a question that is it consistent with AV node reentry, atrial tachycardia, or a VT? So let's always start with the first complex and then go on as we progress in this tracing. So if you look at the first complex.
Albeit we'll take the response from it's a MCQ. And then.
Yeah, okay. We take the response first. Can we have the response?
So we have not set up the poll for this. It's only for yeah.
Okay, let's leave it. So let's look at the first tracing. So we have his. I can't see the A because the tracing starts here. So this is the his. This is a proximal his. And we have the CS electrogram. We can see a small V on the CS, and I don't see the A. It is probably hidden somewhere. Then it is a pacing which is in the right atrium. This is the mentioned as RA. So this is RA pacing. You can see this is a pacing beat. It then goes to CS, then to the his. So it conducts to the his. There is a next. So this is a rapid pacing. You can see a fixed rate of pacing. I don't know what cycle length it has paced, but you see a rapid pacing. Now this A produces this H, and this AH is longer than the previous.
Can you use the point? I mean, it's not seen.
It is not possible for me to use the pointer because
okay.
I will not be able to. So if we see this is a rapid atrial pacing, can't estimate the cycle length, but the second beat of pacing has a AH which is longer than the first beat, right? Now, thereafter, you see the next beat, there is an A, and now the H merges within the V. You can see an H coming out. And if we see this activation, his activation is distal to proximal. So you can see the distal come first, then the proximal his. And this is an LBB morphology. You see this V1, this has an LBB morphology. It triggers off a tachycardia. Now, this is a tachycardia, which is a left bundle branch block morphology tachycardia. I'm going to share one example of an LBB morphology tachycardia, which is regular. But if you look at the H, it is just merged here, and there is activation, which is distal to proximal. And this has been by the atrial pacing beat. The next thing that you want to understand is the initial R of V1 on the ECG. So it is a very rapid initial R. So this tells you that this has to involve the bundle of his Purkinje system to produce this sharp deflection. So what are the LBB morphology tachycardias which can have a bundle branch involvement? One is a Maheim, so that will be AVRT, so atriovascular pathway is one of them, which is very likely in this patient. The second is a bundle branch reentry. Now, the very fact that it was induced by an atrial pacing, so this atrial pacing beat, the third beat, went with a long AH, but the AH turned around from distal to proximal, probably indicating an atriovascular pathway. Over to you, Narasimhan, for your comments on this.
Yes, I think you've heard, whenever you have an atrial pacing beat inducing a broad QRS tachycardia, there are a couple of differentials. So one is, commonest would be an SVT with aberrancy. Second is a thing called as fascicular VT. Fascicular VT is one form of VT which can be induced by atrial pacing. Very rarely, as Dr. Balbir said, especially patients with sick heart, you can have bundle branch reentry. And third is atriovascular pathway. So the crux of the whole thing is looking at the HV interval. The HV interval in a patient with AVRT or any kind of supraventricular tachycardia with aberrancy will remain the same or even slightly longer. Whereas a patient with fascicular VT, you will be able to dissociate the A and the V, and HV tends to become shortened to a variable degree depending on the exit. But this kind of a mechanism where the AH prolongs and then it starts with a left bundle tachycardia is very typical for atriovascular. Even if you are not able to appreciate, as Dr. Balbir said, the reversal of activation, you can see his polarity has suddenly changed. You look at the his tracing where Dr. Ching has marked at AHV, in the bottommost panel AHV, it's negative in the first two beats, and then it becomes positive in the third beat. So the activation wavefront between anode and cathode has reversed, and that is very typical of atriovascular pathway. RV apical catheter is recording an earliest activation, followed by right bundle, his, and then to the A. So in all probability, everything is suggestive of an atriovascular pathway.
So the answer for this is AVRT. Let's look at what Professor Ching will say for this. Let's go on.
And this is a tachycardia that was induced with atrial stimulation. Do these EGMs concur with an AV NRT? 2, an AVRT? 3, atrial tachycardia? Or 4, ventricular tachycardia? Take some moments to make observations and choose the most appropriate response. Let us go through these EGMs and make some relevant and important observations. We first define what is normal P QRST complexes, and the one highlighted or circled in the red box is one such normal beat. Atrial stimulation was performed from the proximal CS. There is atrial capture, and it's conducted down the AV node His-Purkinje system with a narrow QRS morphology. The catheter at the His position records the A, H, and V electrograms. Next, with atrial double stimulus technique, the last pace beat induced a tachycardia. You will note that there is a significant P to Q delay with onset of tachycardia. And this tachycardia is observed to be wide complex tachycardia with a left bundle branch block morphology. This is lead 1, this is V1, this is V6, and a left axis deviation. The VA is constant at 110 milliseconds measured from the QRS, A, and the proximal CS. Now, if you look at the wide complex tachycardia at steady state, as circled by the blue rectangle, you will then begin to see that as you draw a line down from the onset of QRS along the His catheter, the His is now buried. Previously, it was pre-QRS. It's moved within the ventricular EGMs. In fact, the HV interval becomes negative. Now, with these features in mind, one would then be able to rule out an AVNRT because you will need a positive HV interval. At the same time, you will rule out an atrial tachycardia. That leaves us with two options. Is it a VT with 1-to-1 VA conduction, which can occur, or is it some form of antegrade reciprocating tachycardia involving an accessory pathway? And of note, this accessory pathway demonstrates decremental behavior because there was a critical prolongation of PQ interval before pre-excitation shows. Let us move to what we could do to tease out one diagnosis from the other. This is atrial overdrive pacing during tachycardia. You will see that the last 3 pace beats was conducted and brought forward the QRS. On termination or cessation of pacing, there is a A, V, and an A response. And there is concealed entrainment from the atrium. The features of the QRS morphology during atrial overdrive pacing and during tachycardia are similar with these features as described previously. It shows a left axis deviation, left bundle branch block, consistent VA interval of 110 milliseconds, and a negative HV interval. Now, these features make a VT uncommon, because during atrial overdrive pacing, when the impulses travel down the AV nodal His-Purkinje area to depolarize the ventricle during VT, you expect fusion beats or even capture beats. This shows perfect concealed entrainment with morphology identical during atrial overdrive pacing and that during wide complex tachycardia. Let me then move to the last diagnosis, which is an AVRT. To prove that it is an ART, we place a PVC during the His refractoriness. And you would see that in this case, a critically timed PAC is able to bring forward the immediate QRS, resets it, and the tachycardia continues. In fact, when you draw a line from the onset of QRS all the way down, you will be able to discern and observe that the ventricular EGM with the RV catheter placed along the RV septum is very early. Now, this features is consistent with an antegrade reciprocating tachycardia involving an atrial fascicular bypass tract. And these are some of the succinct features observations we made thus far. There must be a critical P to Q delay before re-excitation occurs. Number 2, the wide complex tachycardia has a typical left bundle branch block, left axis deviation morphology. This case highlights the importance of having a good quality His electrogram, because the presence of a negative HV interval helps us make a good diagnosis and rules out other differential diagnosis such as an AVNRT or atrial tachycardia. PAC resets tachycardia, which shows that the atrium is important and part of the critical circuit, and that makes VT unlikely. We have defined with this maneuver the antegrade limb of the tachycardia. And lastly, concealed entrainment from atrial pacing would rule out ventricular tachycardia, for we expect during entrainment from the atrium during VT, you will get captured beat and fusion beat. Thank you for your attention.
So we have seen that a broad QRS tachycardia, which is of LBP morphology, I will bring out one case on that too, has to have a differential diagnosis. So we have to have a regular LBP morphology tachycardia. We have to have a differential diagnosis. We have to give atrial extra stimulation, atrial overdrive pacing, ventricular extra stimulation, and ventricular PVC during His bundle refractory. Only then we will be able to make a good diagnosis. So this is what Professor Ching had just shown. I have a similar case, so I can... Narasimhan, you want to show your case, or should I start? I don't see Narasimhan there, so I'm going to share my screen.
Please get started. I'm sorry.
Okay. I'll just try to share my screen. Okay, let's look at this case. Can you see my slides? I put it in the presentation mode.
Yeah.
Yes, sir, we can see it.
Okay, so this is a young individual with history of palpitations, and this is the ECG. It's not very clear, but frequent episodes in the last few months, and I'll show you the better ECG. This is in the lab. So this is the ECG that we have. Obviously, we understand that there is a delta wave. There's a short PR interval. So I will leave it at that and pose a question as to where this pathway is likely to be. So can we pose the next question? Is this right anterior free wall pathway? Yes or no? So we go back to this ECG and try to understand what it is.
Yes, sir, we're just enabling the poll. Okay. So almost 100% yes.
Yes, so they feel that it is a right anterior free wall pathway. So let's examine this ECG. So we see that the delta in 2,3 ABF is positive. So you get, as Jackman says, give 1 point to each in 2,3 ABF. And how do you distinguish between a right anterior and right anterior? And if you look at V1, there's kind of no positive delta wave. There's no positive R wave. And so this is not an anterior pathway. This is an anteroseptal pathway. So because distinguishing these two helps you to go to the lab, knowing and understanding what the risk is likely to be and where your catheters are going to be placed and how much close and proper understanding you must have. So there are multiple algorithms to try to distinguish, but I will go to this Jackman's slide, which is a very nice slide. If you see the tricuspid annulus in this, I hope you can see my pointer.
Yes, sir.
Yeah, so this is the tricuspid annulus. So this is right anterior and this is right anteroseptal. The difference lies in the fact is look at V1. So you have a fat R wave and you don't have that in an anteroseptal pathway. And it is a huge difference. You may say that this difference is a few millimeters, but this few millimeters is what is going to matter a lot. And when you go with the idea that you are going for an anteroseptal versus anterior, your catheter placement is also going to be a little different. So he mentions a score of 3, which means 2, 3, and AVF are positive. So the score is 3. And this is the initial complex in V1, and this is where an anteroseptal. So knowing that, you understand that this patient has an anteroseptal pathway. I'll go back to the ECG. So what percentage said yes as anterior, right anterior?
So almost 85 to 90%.
Okay, so now it is very important you look at V1. You see the initial downward pointing vector on V1. This is exactly what Jackman has described. So this is likely to be a pathway which is being close to the His bundle. So these parahesian pathways were described by Michel Hezegre, first of all, many, many years back. Now let's look at these tracings of this patient. Fortunately, you can see this is intermittent pre-excitation now. you look at the first three complexes, he has a delta wave. The fourth complex is a sinus beat, and you see the big edge. So as Professor Ching said, that all SVTs, a good His bundle recording is a must. You cannot go ahead and try an ablating, even if it is an AVN RT, without having a good His, because good His gives you an idea what you're doing. Now, if you look at the first three complexes, let's concentrate on the second and third complex, and look at the A and V is very well balanced. And look at this A and V, you see a big accessory pathway potential within this complex. So this bipolar shows you A and V are fused. There is an accessory pathway potential. So this pathway lies right close to the His bundle. This is a clear indication that what we were discussing about the V1 polarity helps you to understand that this pathway is very, very close to the His. And whatever you may do, you have the His there, and you have to have that in mind. Narasimhan, you want to have any comments on this, Tracy?
Very, very important, because only thing is the antegrade pathway seems to be either previously ablated or whatever it is. If it's a robust pathway, that too in the right side pathways usually have a manifest pre-excitation. And to have this intermittent sinus rhythm with a narrow QRS indicates that it's not a very robust conducting pathway in the antegrade. But the tachycardia can be very rapid in these situations. So, as we said earlier, it's extremely important.
So you are right that this patient, when he entered the lab, he had completely manifest accessory pathway. This is the catheter placement, which probably hit the pathway and made it intermittent. So, but you see the electrograms clearly tell you that this is which is located here, right? So go on to the next slide. So a tachycardia is induced. You can see an atrial extra stimulus induces the tachycardia. So the atrial extra stimulus blocks in the accessory pathway, conducts down the AV node. As you can see, the first complex after the atrial pace beat is a narrow QRS. There is some AH prolongation, and then it starts the tachycardia. And this tachycardia, again, you see a big H. The catheter is moving a little bit, so some of the beats do not show an H. You can see this beat showing an H. This has an H. This doesn't have. This doesn't have. Then this has an H. And whichever beat has an H, you can see this is the A deflection during the SVT, indicating where this pathway is likely to be located. So this is the retrograde limb of this pathway during the orthodromic tachycardia, which was induced with the atrial pacing. Now you see a good H on the electrograms, and clearly the A on the His bundle electrogram is clearly the earliest, no doubt about it. In these pathways, if you have a very good sustained tachycardia induced, my idea is to map during this SVT, look in the anterior area, anteroseptal area, and right lateral and mid-septal, so that you have a reasonably good activation lined up for you for ablation. As you can see that we have these yellow dots as the His bundle markers. So these cloud of many 2 or 3 yellow dots indicates where the His is located, and the earliest activation is very much on the His. Now the question is that you have this His. Do you have this anteroseptal pathway? We can pose another question. Should you ablate, or should you leave this patient on medical management in view of high risk of a complete heart block? Yes or no? So those who say that you should ablate, yes. And those who say don't ablate, no. Can you pose this question?
Yes, sir. Activating the pole in 10 seconds, sir.
Yeah, if you say yes, you mean you want to ablate. No means medical therapy.
So 1 or 2. 1 is yes, 2 is no.
Arun, we have few on the chat box also.
So on an average, option A, yes, is 75% and option 2, no, is 24%. In the chat box, we have 4 yeses and 1 no.
Right. So it is possible to ablate these pathways, even though they may be situated very close to the haze. Now, I will show you what. There are certain precautions that you need to take when you ablate these pathways. Precaution number 1 is ablate during SVT. Don't ablate during VPACE. VPACE is absolute no. You will create a block without knowing that you have actually created an AV block. B, sinus rhythm, you can ablate, but it's not the choicest thing to do, because sometimes you may just cause an AV block without knowing, because you may just broaden the QRS, the excessive pathway may conduct more, and the AV node may have just gone. So best is ablate during SVT. Start with low powers. The power started in this case was 20. You can see the SVT was on, and this line shows ablation on. This is where ablation started. 2.4 seconds is where you see a VA block in this pathway. Now, I will bring you to the last line, which is the ablation distal signal. You see a clear H. So one should not shy away that I'm seeing an H. All you need to do is have a small A. Don't have a big A, because the His bundle is located deep. These pathways are superficial. So to transmit energy to the His bundle takes longer time. We already know that in parahesian pacing, to pace the His, you need high output. So His is a relatively insulated structure. AV node is not. So if you have a large A, you may be hitting the AV node. So you can see clearly the A signal is small. There is an H, and this is where we ablated this pathway. You can see a big H on the ablation signal. You see a big V and a very small A on this signal, starting with an output of 20 watts. Maximum 25 was delivered. The pathway went in 2.3 seconds. The lesion was continued for 35 seconds. And at that stage, you can see this is what is happening. We terminated this tachycardia, and the QRS subsequently is narrow. However, which I must show you that this is very common to happen. If you're going at the distal point of the ventricular insertion of this enteroseptal pathway, there is a chance of a right bundle branch block. This patient did develop a right bundle branch block, which persisted till next morning. And at 1 month also, this right bundle branch block is persisting. However, how to prevent this can be difficult. You need to be more proximal so that you don't go close to the right bundle. But in this patient, we somehow couldn't prevent this, because the first beat after the tachycardia termination was a right bundle branch block, but no AV block happened. Then there was retrograde conduction 1:1 with earliest at His. The question was, is this retrograde conduction through His or through the accessory pathway? So this is a parahesian pacing. You look at the third beat, it is a narrow complex. Look at the fourth beat, it is wide complex. So there is a clear delay in the V to A between the third and the fourth beat, telling you that this is from the AV node and not accessory pathway. And following which, we could not induce any tachycardia, and patient is asymptomatic since ablation. So this was the first paper, and they defined parahesian pathways as when the earliest activation is when you record His, which is more than 0.1 millivolt, and you also record the earliest activation at that point. That is when you call it the parahesian pathway. And they also pointed out that V1 negativity, you can see the 3 ECGs, all 3 have V1 negativity, is one of the most important signs in an anteroseptal pathway versus an anterior free valve pathway. And this was the conclusion that ablation is feasible using low increment in energy with preservation of AV conduction, suggesting a subendocardial location of accessory pathway, while His bundle is located much deeper. So it is possible to ablate. You have to be very careful while doing it. You have to ablate during SVT. Start with low voltages. Make sure your catheter doesn't move. So as in this patient, we were on 3D. So even the fine movements would have been picked up in this patient. So this is about an antiseptal pathway and its ablation. So I guess right bundle branch block on the long term will not have any major consequences in this patient who is highly symptomatic. Narasimhan, over to you now for this case.
Very nice case, Balbir. A couple of things. As was mentioned, it's always safer to ablate this during orthodromic tachycardia than during pacing. Second is, if necessary, ask one of your assistants to torque and hold the catheter constantly at the level of the His, because during ablation, during respiration, the His catheter should not move. And third, just make sure that the VA ratio, that the A is quite small compared to the V. And in these patients, make sure that the ratio remains constant over a couple of beats. So if there is a constant change in the amplitude, A becoming periodically larger, that indicates it's an unstable location. Fourth, when the tachycardia terminates, sometimes there can be a volume change. So it is safer to kind of start pacing the atrium at almost the same length as the tachycardia cycle length, or just 10 milliseconds faster. And then as it is going on, you won't capture immediately when the tachy is there. But when the tachy terminates, it will take over at the same rate and the catheter won't drift from that position. So these are a couple of things. Again, if your contact is good, 20 watts may be enough in these patients. The fourth thing is, when before you ablate this, sometimes you may map the non-coronary cusp. Non-coronary cusp is a vantage point for some of these paraSCN pathways, especially in children. And if it's really in non-coronary cusp with a small a, and it's equidistant or earlier than the His, that may be a first sight rather than on the right, because you can still successfully get rid of it without the risk of AB block. Any questions from the audience? Very nice case.
So I'll move to the next case.
Anything from the chat box, ask them to post any queries regarding this case. You can move on, Balbir. Your slides are not visible.
I'm just trying to share them. Okay. Can you see the slides now?
Yeah.
Yes, sir.
Put it on the presentation mode. Okay. So this is a patient, young, 24 years old. This was his clinical tachycardia. So as we can see, V1 is positive, and you can see lead 1 suggests a broad S wave, and we put a polling question. This represents a VT, yes or no?
Enabling the polls. Yeah.
Is this a VT? Yes or no? This gentleman is young. On echo has a mitral valve prolapse, mild MR. So he comes with recurrent episodes. Each episode is like this. The ECG on each of these episodes is like this. Do we have the response?
So it's still going on.
Yeah.
So please allow 10 seconds more. People are still polling. So the results are 58% for option A and 42% for option 2.
Well, if I'm given this TCG, it doesn't mean that I have an SVT module, so it cannot be a VT. But if I'm given this ECG and I don't have any sinus rhythm ECG, and I'm told that this is a recurrent episode, VT can be a possibility. You can see this is not a true RBB. This is all monophasic from V1 to V6. And you cannot rule out VT. And this is clearly any criteria you would try to fit in the Brugada criteria, it will fit into VT. However, now that we are close into this, if you look at lead 2, end of the QRS, there is something. There is something to suggest that it could be a retrograde P wave, but this retrograde P wave cannot also happen in a VT. So to say this is VT is not incorrect. Well, the only close differential diagnosis of this is a pre-excited tachycardia. You have delta wave, you have the initial QRS looks like a delta wave, particularly in V5, V6, and this could be a pre-excited tachycardia, which is regular. So regular pre-excited tachycardia could be a differential diagnosis, but to say this is VT also will not be completely off. Narasimhan, do you want to put any comments?
Yeah, this is an important ECG. In these situations, adenosine sometimes can make things worse by creating atrium will start going into atrial fibrillation. In this situation, when the patient is better would be to give a class 3 drug or cardiovert this patient in the emergency room.
Well, so this patient was cardioverted in the emergency room, and this is the ECG after cardioversion. So it clearly shows pre-excitation and clearly shows a left free wall pathway. So he comes to the lab with accessory pathway conduction in the pathway, which is on the left side. So we clearly see this is the baseline ECG in the lab. However, the moment we tried to enter the CS, this is what happened. So you see a very rapid, broad tachycardia. You can see the cycle length vary between 150 to 260. You see very broad, all beats are broad. You don't even see a single beat which is narrow. The CS electrograms show atrial fibrillation. So this he develops during catheter placement without having done any stimulation, whatever. You can see that his catheter is still not there. It is just the CS catheter which was introduced. So the obvious choice here is to cardiovert this patient because he was getting hypotensive. However, while we were getting ready to cardiovert, he develops this tachycardia. Now becomes regular. From the same atrial fibrillation, he develops a regular tachycardia. Now you can see the V to A response. This is 1:1 response. You can see for each V, there is one atrial activity. We don't have other catheters in to help you to guide what this is, but this is a regular tachycardia, which is pre-excited. We now can clearly show a regular 1:1 response, pre-excited tachycardia. So differential diagnosis could be atrial tachycardia with pre-excitation. It could be an AV and RT going on with pre-excitation. It could be an antidromic tachycardia. So antidromic tachycardia means it goes down the accessory pathway, comes back on the AV node. So that is an antidromic tachycardia. So it could be any of these three, and we have to do maneuvers actually to distinguish between them. So we did the first. This is the regular tachycardia with 1:1 VA response, similar to what I showed you in the clinical example. So in his actually clinical part was this exactly what he was having. So as I was mentioning, antidromic tachycardia classically has the impulse going down the pathway and coming back on the AV node. But you can only distinguish it by doing maneuvers, which is atrial and ventricular pacing. I was scared to do atrial pacing for the simple reason that it could end up in the tachycardia degenerating again into atrial fibrillation. So I did a ventricular pacing. You can see I started with just shorter cycle length than the tachycardia. And this is what happens. The QRS, from a broad QRS complex, it becomes a narrow QRS complex. We go to show you the intracardiac electrograms. The CS electrograms are there. His are there now. This is the ventricular pacing. So from ventricular pacing, we convert an antidromic tachycardia into an orthodromic tachycardia. So how is it possible that by pacing the ventricle, that to the right ventricle, we get this kind of a complex? So this answer is simple, that when you pace the RV, there is a delay from RV going to the LV. This is a left lateral pathway. When it reaches that, it collides with the impulse coming down the antidromic tachycardia, stops it, but it retrogradely proceeds over the pathway retrogradely into the atria. You can see the first three ventricular paced complexes show that it goes down the retrograde pathway and then starts in orthodromic tachycardia. But it doesn't stop here. This discussion doesn't stop here, because if you see the last two beats, the retrograde conduction is now totally different from what you were seeing. You stopped, and this is an orthodromic tachycardia, I agree. But what about these two last beats? They are not through the pathway. So now you see a very short VA, and they seem to have gone back through the AV node. So the pathway has got fatigued, and then these two beats have gone back retrogradely through the AV node. So does this patient have antidromic tachycardia, orthodromic tachycardia, and an AV NRT? So he may be having all that, and that antidromic tachycardia may well be an AV node re-entry tachycardia with antidromic tachycardia down the line. I did not do more maneuvers. I did not try to induce more because of the fear of atrial fibrillation. Let's look at Sunny Jackman's clinical case example. This is a tachycardia very similar to what I showed you just now, an RBB morphology, broad QRS tachycardia with 1:1 VA response. So see, the HV is negative in this tachycardia. Each V is followed by an A, exactly like what I showed you. And the earliest activation of the A was close to the Hayes bundle catheter. So it could be a retrograde through the AV node, or it could be another pathway. So how do you distinguish that? The first thing is, this is an atrial excess stimulus from the right atrial appendage, did not cause a change in V to V interval. So now, as I said, the differential diagnosis is VT or antidromic tachycardia, or one of those which I mentioned. So first thing you want to rule out is a VT. So this does not cause a change in V to V interval. A pacing at the distal CS, which is close to the accessory pathway, changes this relationship clearly, and the V becomes more earlier than what it was. You can see it's 470 and 435. Two beats have been taken into. So V has been advanced, which can only happen only if atria is a part of the circuit, and this rules out VT. So Professor Ching also showed you that atrial extra stimulation or atrial pacing helps you to distinguish whether this is VT or not. By advancing the V, by pacing on the atria close to the pathway on the distal coronary sinus, you rule out a VT. Then a PVC during his bundle refractoriness caused again advancement of the A. Now this tells you clearly that the retrograde limb of the pathway is not AV node, it is an accessory pathway. So in this patient, which Sunny's example, there is an antidromic tachycardia with the retrograde limb on the another accessory pathway which is going there. So in short, this helps you to distinguish from VT, helps you to look at the retrograde limb of the accessory pathway. So atrial excess stimulation followed by a PVC during his bundle refractoriness can answer these two questions. So in our patient, it's just an overdrive, atrial overdrive pacing converted this antidromic tachycardia into orthodromic tachycardia. And this was enough for me. I didn't want to reinduce atrial fibrillation or antidromic tachycardia. I went ahead. This is the last two beats which I was showing you. I went ahead and ablated at the earliest point during sinus rhythm without trying to induce too many tachycardias. We know AFib is bad to have. One burn you can see the accessory pathway conduction finish in the. So this is a successful burn. You can see the distal CS change with the fourth beat into a normal beat. So accessory pathway conduction was gone. There was retrograde conduction close to the AV node. Adenosine was given showing a VA block. But interestingly, with atrial extra stimulation, we induced an AV-NRT. And those two complexes, I was really concerned that I must do atrial extra stimulus because this patient may also have AV-NRT. And so an AV-NRT was induced by an atrial extra stimulation. This was known from the previous tracing that we saw during orthotropic tachycardia. After a slow pathway ablation, you can see this atrial extra stimulation block with no H prolongation, so the slow pathway conduction was gone. So this brings you to the importance that just having ablated the accessory pathway does not mean that you may have done the job fully. There may be another accessory pathway which may be lying, which you were completely oblivious during the study. And there may be an AV node reentrant tachycardia which may be going on, and you may miss that completely. In this patient, this tells you that probably that antitromic tachycardia was an AV-NRT with a pre-excited tachycardia down the accessory pathway, which possibly is the cause, though I have not done his bundle refractory PVC during the antitromic tachycardia because the catheter wasn't there. And when I got the catheter, it got converted into an orthotromic tachycardia. So this is the post-ablation ECG, and the patient is asymptomatic and without any problems. Over to you, Narasimhan, for this case.
Very nice case again. As you saw, that patient presented with a regular broad QRS tachycardia and then a pre-excited atrial fibrillation. This makes it difficult to map in the lab. Number one is to keep this patient very well sedated. And even during AFib, if you have roughly localized where the pathway is, the ventricular insertion will be very early. So even when there is a varying cycle length, if the patient is, you need to quickly learn to map the earliest V and ablate this even during atrial fibrillation. There are some patients who will be repeatedly going into atrial fibrillation. The moment you ablate the ventricular insertion or near the accessory pathway, everything will be gone. So that is one thing. We have seen this both with pre-excited Maheim as well as with pre-excited pathways. And the third is the site of PAC. Whenever you have a pre-excited tachycardia, and that is the differential, that it's an antidromic tachycardia, and you want to confirm, the PAC should be delivered at a late PAC that should be delivered close to the insertion of the pathway. So you see the right atrial appendage PAC did not pull in or advance the V, but a distal CS PAC advanced the next V. That is fairly typical of an antidromic tachycardia because the late PAC needs to be delivered at the site of insertion of the pathway. Very nice case.
Narasimhan, you want to show or shall I show the third one also?
Yeah, you can show the third one.
Okay, let me go to the next case.
Meanwhile, are there any questions in the chat box?
Yeah, there are quite a few questions, sir, which are coming up.
Yeah, you please tell us what are the questions.
In slow AVNRT, even after ablating the retrograde slow pathway at earliest A, do we still... One second.
Can you bring it up?
Yeah. Yeah, do we still need to knock off the RIE location? And there is one question
in the chat box, please. Can you forward the question?
Yeah, it is there on the chat window only, sir. I mean here. Yes.
Balbir, are you able to see?
No, I'm not.
It's on the Zoom chat, sir.
You can only see the welcome message.
So there is one question.
Doctor.
Antidromic tachycardia with left lateral pathways. V is short, AV-NRT. Wonderful case. How to define late PAC, Dr. S.K. Datta?
Yeah. And as we go up, I think we have other questions from Dr. Shaktivel, Dr. Ram, R.D. Yadav.
So the late PAC is when the HIS A is getting activated. So roughly you look at the A in the HIS, and at that time, deliver a PAC at the level of the possible insertion site of the pathway, and then start scanning the cycle. You had some question regarding AVNRT.
So the question on AVNRT is in a slow pathway, after knocking off the slow retrograde limb, do you still do AIE? I don't understand what is AIE. It probably means atrial extra stimulation. Yes, you have to do. I really don't understand this question.
Can you rewrite the question? I'm sure there's someone who's listening, the person who asked the question. Can you reword it properly, please? I'm not able to understand the question.
So there's one more question. How can AF be coexistent during antidromic AVRT?
So it cannot be coexistent. Either you have antidromic AVNRT or antidromic tachycardia, which may be AVNRT, atrial tachycardia. You have to have 1:1 relationship between A and V to have this antidromic tachycardia. If you have atrial fibrillation, you lose that. It becomes an irregular tachycardia. There is no relationship between A and V. Some of the impulses go down the pathway, some AV. So it's a completely different story. AF and antidromic tachycardia.
I think the question is, see, the patient will start off sometimes with a a broad QRS regular tachycardia, flip into atrial fibrillation, and as sedation and the patient calms down, it will come back into regular antidromic tachycardia. So atrial fibrillation, it will temporarily degenerate. It's like VT degenerating into VF or a polymorphic VT. And then when you give a drug, sometimes it organizes itself into into a regular tachycardia. So the patient can flip from a regular antidromic tachycardia to a pre-excited atrial fibrillation and vice versa. But very often flipping back from pre-excited atrial fibrillation back to regular tachycardia is uncommon, but we do see it commonly in the EP lab, like what Dr. Balbir's case was illustrated of.
Sir, there is one more question from Dr. Ambudar. How to differentiate septal accessory pathways versus atypical AVNRT?
So this is quite important because one of the most useful maneuver here is VOP. When you do a ventricular overdrive pacing, the return beat post PPI minus TCL will be usually more than 110, 120 milliseconds in AVNRT, much longer, 130, 140. Whereas in septal accessory pathway, because you are directly entering the V, the return beat will come much faster. So PPI minus TCL will be around 80, 90. Now, if you are left a little confused, the best thing to do is deflect your catheter and do the overdrive pacing from close to the tricuspid annulus. Because when you do that, you are exaggerating the difference between AVNRT and septal accessory pathway. So do a ventricular overdrive by deflecting the catheter and placing it at the base of the ventricle, that is close to the annulus, and entering. So if you do this in the septal accessory pathway, the return beat will be much, much shorter, and the AVNRT will be much longer. So this will exaggerate the difference.
Thank you, sir. So we'll take one more question. I think in a non-inducible tachy with ECG documentation suggestive of AVNRT and single echo only in lab, what should be the endpoint of ablation?
So this is a very difficult situation. So if you have a single echo and it is not induced, this was also posed to Nitish Padwar, and he said that we always give a lot of isoprene and most of the times we'll be able to get the tachycardia. But if not, I think we have to abolish that echo also. I will not be satisfied if I go home, start with an echo, and end up with an echo, and I think that I have been successful. I don't think I will be satisfied with that.
So, couple of things. Number one, inducibility. First of all, you should look at the mechanism why it is not inducible. Suppose you have a brisk VA, but the AV is low, then you can use sometimes atropine can bring this on. More than giving more isopril. What happens when we give isopril is both VA and AV will accelerate and they will collide. And it may make it difficult for you to induce this tachycardia. The second thing is, if there is a fractionation of the pathway potential in the slow pathway area, pacing from CS area may bring out the tachycardia rather than from high right atrium. So if you have done everything and still the tachy is not inducible, one of the important points is to look at the crossover. So Wenckebach cycle length from the atrium is a manifestation of the property of slow pathway. So if the Wenckebach cycle length significantly, it should prolong if you have successfully ablated, and the crossover should be abolished. So if you still have a crossover, that indicates that there is a presence of slow pathway. So in this kind of situation, as Dr. Balbir was saying, it's difficult. There are no clear-cut guidelines. But if in a highly symptomatic patient, it's prudent to abolish the echo. If you're not able to at least show that you have changed the Wenckebach cycle length and you have abolished the crossover when you pace from the atrium.
So I'll now go to my last case.
Rajiv, all the questions have been answered?
Yeah, as we, go to the presentation, I think we have one more question which is there on the chat box. I think we can go to the presentation and then take it.
Okay.
Thank you.
Okay, we just saw a right bundle branch block, morphology tachycardia. Let's go to an LBB morphology. So this is a patient who has multiple episodes, and this is what is recorded during the episodes. So we can clearly see it is a left bundle branch block morphology tachycardia. And question is it typical left bundle branch block or atypical? That's the first thing. So my question, which I'm posing to the audience, is this VT or no VT? Yes or no?
Enabling the question on the webcast, sir.
What are the responses?
Polling is still on, sir. We're still getting the responses. So option B is 90% and option A is 10%.
Good. So most people think it's not a VT. So let's look at how do we decipher this ECG. First thing you have to say is this typical of LBB? You see a notched R wave in one AVL, V5, V6. You see RS in V1, absence of Q wave in V5, V6. So this is the criteria to diagnose LBB, and it has a typical LBB. You can see a notched one AVL, V5, V6, initial R wave. Now the next thing that you have to look at the initial R wave in V1. This is a very sharp R wave in V1. And I will take you to two big experts on this. One was Masood Akhtar. And I still remember Valens was visiting Milwaukee and I was there. Narasimhan was there that time. And Masood took a lot of interest in this sharp initial deflection because he has done tremendous work in bundle branch reentry. So he said that if the initial deflection in V1 is sharp, it has to be activated by the His bundle system. Same is what George Klein has said, that it is, everybody tries to remember Brugada, Valens criteria and other criteria to distinguish VT from SVT. Look at the morphology of bundle branch block. If not typical, it is not SVT with aberrancy. So here we have a typical left bundle branch block. And if you look at V1, it tells you the deflection is very sharp. So the differential diagnosis of this typical LBB, so we accept that this is typical LBB, is SVT with fixed LBB, SVT with LB aberrancy, pre-excited tachycardia using atriovesicular pathway, AVNRT with a bystander atriovesicular pathway, pre-excited tachycardia using a nodovascular pathway. So here you can have a VA block, a bundle branch reentrant VT or a focal VT from the right bundle. So this is all the differential diagnosis that you have for this tachycardia. So this is what we have in the lab. So when we have such a patient, it is very mandatory. You map the whole right bundle and the His bundle properly. It is not a quadripolar which will serve the purpose. You can see in this patient, we have a decapolar introduced into the His bundle system. We start with the top tracing, which is the distal right bundle. We come down to the proximal His bundle. So this part of the tracing has to be mandatory if you want to give a differential diagnosis to this kind of a tachycardia. You would see in the sinus rhythm, there is no evidence of pre-excitation. The second thing is that we could able to induce the same tachycardia that was there earlier. Now, this is an important step, that this is pacing from the right atrium. So you must pace from the right atrium, not from the CS electrograms. You can see we have the CS electrograms, but we are pacing from the right atrium. So we have the initial complexes, the first four of them, which are broad, which mimic the tachycardia, which is the left bundle branch block. And the last one, which is narrow. But more importantly, is to look at the activation of the His bundle. How does it happen? When it is broad, you see the first one, the distal His or the right bundle is first. And as you come down, it is just the opposite. While here, during the beat, which is narrow QRS, you see the His bundle is first and the right bundle is the last. It's complete reversal of the sequence of activation of the His bundle catheter. Now, this is atrial pacing, and it resulted in conversion of this AF into a flutter. And some of the beats are broad, some of them are narrow during this atrial pacing. Now, with this, we come to the conclusion that we are dealing with something which on atrial pacing reverses the sequence. So that means atria is a part of the circuit. So when you pace the atria, you get LBB morphology complexes, which exactly match the left bundle tachycardia, which reverse the sequence of His bundle activation, telling you that this is a pathway which needs atria, particularly right atria, because you get this on right atrial pacing, not on CS pacing. Also, it reverses the sequence, tells you it is attached quite distally towards the His bundle. Another thing to note is the V electrogram is missing here. So the V, which was located beyond the His bundle, was the earliest during this pacing, telling you again the fact that this was a pathway located. Now, so having made a diagnosis of an atriovascular pathway, we went ahead and ablated this pathway on the this had a failed ablation earlier on the proximal site on the annulus. This time we went on the distal part. You can see this is the electrogram, the ablation catheter, proximal distal, shows a potential far away from the his. And we have presented our paper that ablating during atriofascicular during sinus rhythm has a very good sign, which is called Mahim accelerated junctional beats. So you see the acceleration of the atriofascicular beats exactly like what AV node reentry has. And we get this and we find this as one of the best markers. This is atrial pacing after ablation, no LBB morphology, and the tachycardia cannot be induced. But these patients very commonly also have AV nodal reentry. So this is an atrial extra stimulus, goes with a conduction on the slow pathway. You see a H jump followed by 2 echoes. And this was an ill-sustained AVNRT, which also we ablated. Now, this is to show the catheter placement. So we have one CS, we have one atria, the high right atria, and a decapolar in the his, starting from the right bundle to the proximal part of the his. And the pacing catheter is on the distal part. We don't pace from the RV apex, pace distal to the right bundle. So this is the catheter placement. This is the site where ablation was successful. This is distal part of the accessory pathway. This was the his bundle. You can see it's far away. This was the ablation catheter, and this is far away from the his bundle, but had potentials which looked very similar to his bundle potentials. This is the tachycardia, and you now see how early V is. You see the RV apex, this is the distal part. How early is V in comparison to tachycardia? If you put a line, it's almost earlier than the V onset, telling you that how distally these pathways go and attach themselves. And this is during catheter manipulation, we terminated the tachycardia which is going on. And you can see the distal potentials during tachycardia in the catheter, which is placed distally. And distal ablation can produce right bundle branch block. This patient had transient RBB, which disappeared next morning. And this is the ablation of this cath. This distal yellow dot is the right bundle potential. These ones are his bundle potential. And this is the distal insertion of the catheter. So, in this atriofascicular pathway, you have something like an AV node. This inserts into the distal right bundle, then goes back through the AV node and comes back through the accessory pathway. So this is basically an antidromic tachycardia with pre-excitation through the atriofascicular pathway. And it could be an AVNRT going on, which is causing return cycle from the atriofascicular pathway. In this patient, we induce AVNRT after the taking care of the accessory pathway. So this is similar case to what Professor Ching showed, but we had shown clearly the his and the right bundle tracings and distal ablation. So distal ablation is not one of the most preferred ones. You want to go more proximally, but unfortunately, maybe catheter stability was less, or we were not able to achieve a good result with the proximal ablation. So a distal ablation was successful. Over to you, Narsimhan.
Yes, a nice case. First is to highlight a couple of things. One is to pre-excite and advance. Most of this work very well when you try to deliver the PACs from the right atrial appendage. And if right atrial appendage doesn't advance the V very well, but the PCS advances it easily, then the pathways are more likely to be in the posterior sector. Whereas the right atrial appendage advances it, most likely it is the classical location, which is in the posterolateral location. Approximately 10 to 15% of the patients, we may not be able to distinctly record a Mahim potential. And in these patients, it may be prudent to kind of go to the insertion site, but be doubly careful, map multiple areas, and you need to be sure that there you will get an insertion potential. Like what was seen in this patient, a small potential followed by a V. And that should be the earliest one preceding everything else. then that is a next best option. Approximately about 15 to 20% of the patients may need this.
Let's look at the chat box. What are the temperature settings? So it depends on what catheter you're choosing. In this patient, we had used an irrigated tip. So temperature setting is 45 degree when we use the irrigated, 60 degree when we are using a non-irrigated. How can AF be coexistent with antitropic AV and RT? It cannot be. Then how to differentiate between septal? This is done. Retrograde A in a wide QRS tachycardia, whether eccentric or concentric, will determine whether dual pathway tachycardia, but its refractive PVC is important when concentric. Yeah, that is true. If it is concentric activation, you have to give his refractive PVC, because that can help you to distinguish whether it is going back through a septal accessory pathway or through the AV node. That is correct. In that, we complete. I think we have answered most of the questions here. Yeah, Rajiv. Anything you can see which is not answered?
No, sir. I think this is fine.
What would you consider using cryo for ablation for anteroseptal pathway? So, very good question. So, tomorrow I'm doing an anteroseptal pathway with cryo. It's very I think there's a lot of confusion as to why cryo is more useful in some pediatric AVNRTs and anteroseptal pathways or septal accessory pathways. We had Nitish Badwar pose this question, and he's thought that cryo can also produce AV block. It is not completely 100% that you will not get a AV block with cryo. But yes, cryo will be safer for ablation of anteroseptal pathways.
Thank you. So if there are any questions who are there on the call here, if they want to open up and then ask, please do ask the questions. Or you can post it in the chat box. So doctors who have attended all the 7 sessions, maybe you can also share your feedback. I mean, by opening up your, by unmuting yourself.
Yeah, we can hear comments from those who can unmute and speak.
Good morning, all. Thanks for the effort made by Abbott, and thanks to all the legends. Without their tight schedule, they helped us to go through this valuable journey. Regarding the atrial accessory pathway and the so-called right-sided pathway, sometimes we need to have, or we feel like that we need a valuable opinion by listening to others' cases. We need to have special hardwares, because they spend very minimum amount of time in diagnosing the pathway localization, whereas after having done that, they need more time for ablation of the same. This is what I attended at least 4 or 5 cases under various experts in this field. I really need your valuable comment upon the same. So having a catheter which is having the dual function of sensing as well as delivering the ablation, if that kind of catheters are available for right-sided atrial accessory pathway, that can help us more. That's a gut feel. But what is the limitations, or what kind of feedback or update? Please welcome, sir. Thank you, sir. Thanks for the opportunity.
So most of the times I see the misdiagnosis of intravascular pathway. So many times they are misdiagnosed as VT. So just right atrial pacing, not pacing from the CS, is able to tell you what you are dealing with. Second is that like right lateral accessory pathways, these pathways are difficult because the tricuspid annulus is big. So a use of sheaths can be very helpful. Then coming from above downwards, so you scale up the tricuspid annulus and come downwards, gives you very good support with the catheter and very diligent search for the potential. So you should jack up the gains on the system because sometimes they can be very small and these small potentials may be missed if you're not jacked up the gains. Jack up the gains on the system and you would be very, very clear what's to happen. The third thing is if you are on a 3D system, it really helps because sometimes you bump these pathways. And when you are bumped, you can clearly mark on the 3D system where you bumped. Supposing you don't get the pathway conduction after waiting for some more time, at least you can give some burns in that area to take care of the pathway conduction. So it is like you should go with an open mind. You should go with the idea that you could take a longer time than normal in these pathways. Plan your cases well in advance because you have the ECGs with you when you get this patient. Diagnosis is not so difficult. Atrial pacing, giving a late atrial extra stimulation, and looking at the response of his refractory PVC can be very useful in these patients. Narasimhan, you want to add some tips for ablation of atriovascular?
One of the important thing is do not start the first burn till you're mapped very well. The commonest reason is once you burn the area extensively in this area, you produce lot of delayed atrial potential, which will mimic. That's the problem in reablations of Mahaim. You'll get a very far field late activated A, which will resemble like a Mahaim potential. In the first ablation, generally you see a sharp potential. Of course, it can be very small unless you amplify the signals. But before starting up to ablate, it's better to map a little above and below the putative site of insertion. Make sure that you're really on the annulus and getting a stable Mahaim potential before starting up the ablation. I think.
I think.
So Rajiv,
we can move to the adjourn and wrap up session, sir. Yeah.
Yes, we can wrap up.
Yeah.
Yes, sir, your comments on the module wrap up.
So I thank everybody. I thank Narasimhan, and we are ready to wrap up our 7 series of SVTs, which has been very interesting. A lot of hard work has gone into developing these sessions, recording cases, and I hope that we have served the purpose for which these symposiums were meant to do. And APHRS, Professor Xian Chen and Professor Ching, they gave us a great opportunity to do